Hello, my name is Isabella Tahalweg, and I'm recording this chapter on prognosis after traumatic brain injury on behalf of Professor Ewout Stijberg, Professor Andrew Maas, and Dr. Hester Linksma. In this chapter, we aim to summarize the literature on state-of-the-art approaches to prognostic analyses, our current knowledge on prognosis in TBI, and discuss the development, validation, application, and limitations of prognostic models for patients following traumatic brain injury. The objectives of this presentation and related book chapter are to define the importance of prognostication in TBI, differentiate between prognostic factor and prediction model research, identify challenges in prognostic research, summarize predictors of outcome after TBI, describe a framework for development, validation, application of prognostic models, and consider future directions. For patients who have sustained a TBI and their families, prognosis is of major importance. Much interest has been focused on prognosis following TBI, but due to the heterogeneity of the condition, it has been considered difficult to say what the likely course of events will be in an individual patient. Research has shown that physician estimates of prognosis are often unduly optimistic, unnecessarily pessimistic, or inappropriately ambiguous. With prognostic analyses, we aim to support physicians' intuitive estimates of patient outcomes over time. In practice, prognostic models can be used to make individual predictions or group-level predictions. Individual predictions can support physicians and help to inform patients and their relatives on prognosis. Group-level predictions can be used to stratify patients for clinical trials, to support medical decision-making, and to support quality of care assessments by comparing predicted and observed outcomes, or in other words, benchmarking. Prognostic factor research involves studies with a focus on the prognostic role of specific patient or disease-related characteristics in relation to outcome. We refer to this as independent, meaning that it is independent of the effect of other factors on the outcome. It should be stressed that this univariable association does not account for the role of other factors that might be important for the observed association. You can, for instance, look at the independent effect of age on mortality or the independent effect of GCS on mortality. In contrast, prediction modeling studies focus on the combined effect of various prognostic factors in predicting the outcome. Multivariable analysis allows us to explore the unique predictive value of that factor over and above that of other predictors. Prediction models combine multiple factors to predict an outcome at a specific time for an individual patient. There are many challenges in prognostic studies. Some of the most important challenges relate to sample size, which predictors to include and how to define them, how to handle missing data, and which outcome measure to use. The sample size should be sufficient to study a prognostic factor or develop a prediction model. Later in this presentation, I will explain how you can determine if the sample size is sufficient. The choice for a predictor should be based on subject matter and clinical knowledge. Predictors can be analyzed continuous, ordinal, categorical, or binary. In many studies, continuous or categorical predictors are collapsed into a binary variable using threshold values. In general, it is preferred to exploit the full information available and analyze the ordinal or continuous predictors instead of dichotomizing predictors. Missing data is common in medical research and should be handled efficiently. Removing patients with missing data from the analysis is statistically inefficient and may lead to bias, because there might be systematic differences between patients with and without missing data. More effective approaches to deal with missing data are single and multiple imputation techniques, in which missing values are imputed with plausible values. In TBI, the Glasgow Outcome Scale or Glasgow Outcome Scale Standards are typically used as functional outcome measures. In prediction model research, the scale is often dichotomized into mortality versus survival or unfavorable versus favorable outcome. Prediction of outcomes using more granular outcome assessments have been proposed, including measures of cognitive functioning, neuropsychological tests, and quality of life assessments. The main predictors of outcome following traumatic brain injury can be grouped together into building blocks, which include genetic constitution, demographics, clinical severity, secondary insults, structural abnormalities, laboratory parameters, and biomarkers. Many ongoing research efforts are focused on the prognostic effect of biomarkers and advanced imaging, which have the potential to further improve prognostication in TBI. The strongest predictors of mortality and unfavorable outcome following moderate and severe TBI are age, the Glasgow Coma Scale Motor Score, and pupillary reactivity. For mild TBI, prognostic models are less well established, and patient characteristics might be of more relevance to prognosis than injury-related characteristics. Many prediction models have been developed to predict outcome after moderate and severe TBI. However, several reviews showed many shortcomings in model development and lack of external validation. The impact and crash prognostic models are well known and have been extensively externally validated. They were developed on large data sets over a decade ago and include age, clinical and radiology variables. Below you can see the different versions of the impact and crash models with increasing complexity. In our chapter, we have used these models as an illustration of established prognostic models for outcome after moderate and severe TBI. As mentioned before, methodological shortcomings in the development of prognostic models are common. Therefore, attention to the methodology of model development is required, specifically to coding of predictors and specification estimation of the model. Before we discuss these steps, it is important to understand why we want to avoid methodological shortcomings. If the model is not developed in accordance with methodological principles, the model is likely to be overfitted. This means that the model is fitted too closely on the available data, and the prediction model does not generalize to new patients and settings. As a consequence, the model is likely to under or over predict the outcome for individual patients and might therefore be unreliable or even dangerous to be used in practice. With the first step, problem definition and data inspection, we want to ask ourselves, what is the research question? What is the outcome of interest? What is already known about predictors, and are there any missing values? For the coding of predictors, we typically look if categorical and continuous variables require recoding. However, dichotomization of a continuous predictor should be discouraged, and a continuous approach to analysis is preferred. Model specification relates to questions about which predictors we should include in the final model based on prior knowledge and how many predictors can be included. The maximum number of predictors that can be included can be estimated by dividing the number of events by a factor of 10. For instance, when you have 50 events, you can include 5 covariates in the model. If you exceed this number, the model is likely to be overfitted. Model estimation relates to the statistical model that is used to estimate the regression coefficients, which is typically done with regression analyses. To reduce overfitting, modern estimation techniques including lasso, ridge regression, and elastic net can be considered. Model performance, validation, and presentation will be discussed in more detail in the upcoming slides. Model performance should be assessed in terms of discrimination and calibration. Discrimination relates to how well the model can distinguish between high-risk and low-risk patients, as expressed with the area under the ROC curve, or the AUC or C statistic. Calibration relates to the accuracy of the model, so do the predictions agree with the observations? When a model is developed, the next requirement is external validity of the model. External validity relates to the generalizability of the model to another population. In other words, in external validation studies, we aim to assess how the model performs in new patients and settings. For example, the impact models were recently externally validated in contemporary patients in the Center TBI study. We found that the impact models adequately identify patients at high risk for mortality or unfavorable outcome. Thus, they had adequate discrimination. This means that we support their use in research and for benchmarking. We also found that there were discrepancies between observed and predicted rates of mortality and unfavorable outcome. Thus, there was variable calibration. Therefore, it is crucial that the model is adjusted to local hospital and patient characteristics before the model can be considered to be used in clinical practice. The final model can be presented in several ways, for instance with a regression formula, a nomogram, a score chart, or a web calculator. On this slide, you can see two web calculators, one for the impact and one for the crash model. The regression formula should always be provided to enable others to validate the model. A nomogram, score chart, and web calculator might facilitate implementation of the model in practice. So, what are the main conclusions? We know now that the main predictors of outcome following TBI can be grouped together into building blocks. Following modern severe TBI, it might be more important what the injury brings to the patient, so injury-related characteristics, for a prediction of outcome. However, following mild TBI, it might be more important what the patient brings to the injury, so patient-related characteristics. Typically, we use the GWAS-E to predict functional outcome following TBI. But the GWAS-E is a broad outcome scale which might not be sensitive enough in mild TBI patients. So we suggest also looking at multidimensional outcomes for more patient-reported outcomes. We also know now that high quality and well-validated models exist for outcome after modern severe TBI, but models for mild TBI are less well established. When developing a prediction model, it is very important to adhere to methodological guidelines and principles. Advancements in prognostic research are likely to result from a consortium of several international research groups. It is important to adhere to key methodological principles, and it can help to use reporting guidelines such as the tripod guidelines. Model performance may be enhanced with the inclusion of biomarkers and advanced imaging. Prognostic models for mild TBI should be developed, validated, and further improved. Furthermore, prediction models should be developed for more multidimensional and patient-reported outcomes.